So, this is basically a talk on transcatheter closure of ASD in small children, and arbitrarily I took less than 15 kilos. Let me thank on the outset Dr. Shiva for inviting me to my old place, Triple M. So the umbrella device was first inserted in December 1972 by Kings and Mills. Our story, number of cases 118, duration from June 2015 to June 2019, that is about 4 years, and age was mean of 3.8, ranging from 1 to 8 years, and weight 12.5 kgs, ranging from 6 to 15 kgs. Demographics, male and female, naturally female were more, and less than 10 kg and more than 10 kg. Less than 10 kg was 16%, and more than 10 kg was 84%. How did they present? Incidental detection of murmur in about 50 cases, and recurrent RTI in about 41 cases, shortness of breath in 23 cases, and failure to thrive in 4 cases. Device size, defect size was mean of 13.8, ranging from 8 to 24 millimeters, and device size was 16.4 mean and 10 to 26 millimeters range. Device patient ratio was mean of 1.32, patient weight ratio 1.32, and the range was 0.67 to 2.3. We were successful in about 109 cases, there is 92%, and we attempted in 9 cases, that is 8%. Now, attempted cases, in some cases, out of the 9 cases, some did not fit. There was external iliac narrowing in one of the cases, and then RUPV occlusion, and again extra iliac narrowing, and they did not fit properly, so it was taken out. So the yellow line is basically the patient's weight versus the blue line, which is the device size. And device weight ratio was maximum 2.3. So I will show you a few cases. A 1-year-old girl weighing 6 kgs, CCF refractory to medical management, and 12 millimeter ASD with deficient IVC and retroaortic rims, and 14 millimeter occluder was used. So there's the device being applied. Next case was a 4-year-old 10 kg and 14 millimeter ASD with deficient IVC rim, and 16 millimeter occluder was used. Yeah, so that result was also good. Third case, 7-year-old girl, 14 kgs, 16 into 21 millimeter ASD with small floppy IVC and deficient retroaortic rims, and 26 millimeter ASO slipped out easily, so we referred this patient for surgery. One-year-old 10 kg boy with 14 millimeter ASD and 16 millimeter occluder. This is from the right upper pulmonary vein technique. Three-year-old 10 kgs girl 18 millimeter ASD, and 20 millimeter occluder. And this patient had severe pulmonary hypertension in the newborn period, and we did PDA device. There was a PDA and a sizable PDA and an ASD. So we closed the PDA in one setting and then gave him all sorts of pulmonary vasodilators, and then we closed the ASD after 3 years. His PA pressure now on follow-up is absolutely normal. This is another typical, very interesting result. A 4-year-old 15 kg boy with 14 millimeter ASD, but delivery sheath could not be negotiated due to external iliac narrowing. So the delivery sheath could not be passed through this very thin vein. (17 millimeter ASD in 3-year 12 kilo boy we attempted with 20 millimeter occluder. Luckily, I was saved in this case because it was going to form a cobra deformity. Final result was good. So if you go to the literature review, then in this periodic cardiology journal in 2017, 252 children are reported and larger ASD associated with the increased risk of transient arrhythmia, and post-procedure in hospital complications were comparable to older children. And transcatheter device closure of secondum ASDs can be performed safely in infants less than 15 kilos. This is another review in JACC in 2012. 128 children, 98% procedural success, 1% residual leak, and more than 92% rate of resolution of right heart enlargement. And in small asymptomatic children, deferral of closure till historically established timeline of 4 to 5 years. There is another in Journal of American College of Cardiology in 2018, where they have shown about 1395 cases up to 18 years. Procedural outcome was 95.3% and complication rate was 1.8%. And complications were more in children less than 15 kgs, including pericardial effusion, conduction anomalies, and mitral regurgitation. This is another journal, the same journal, follow-up till 3.5 years. Only late complications were pulmonary hypertension. It persisted and related to selection of the patient at the outset. Thank you. But the message is that you should not keep on trying with bigger and bigger devices as it goes. You have to know when to stop.
Thank you, sir. This is Shupratim. Just a question. Do you have an upper limit of device size to patient's body weight that you go by, or do you not follow any limits?
No, actually, you see, there is a lot of recommendations by different school of thoughts, and people just say that you can go up to 1.5 times the body weight. And there is another principle is that the atria has to be big to accommodate a big device. That's important. And the other thing is, when I've seen in one or two papers, like when you put the device in the closed fashion in the heart, suppose you are in the right or pulmonary vein, the device should not cross the diaphragm. Then it is diagonally, if you cut the heart, and then it should not cross the diaphragm. Then it is a big device.
Okay, thank you.
Yes?
Someone is asking if you or anyone in the audience has anyone attempted ASD device closure at 5 kilo weight. While we are discussing, I would like to invite our next speaker, Dr. Krishnamurthy, to come and so that his talk can be loaded. And while that is being done, we can take one or two comments.
Actually, we have done, sir.
Yeah, I have not done bill.
We have done, Biswajit, 4.5 kilogram baby you have done. That's a baby who had severe failure to thrive because of the ASD. We have closed the ASD in the 4.5 kilogram baby. Usually we don't do, it's about 10 mm ASD.
Personally, I haven't tried. Personally, I haven't used a device in less than 6 kilos.
Sir, one more question. Any preferences of right upper
Yes.
pulmonary vein and parking in left upper pulmonary vein suiting the anatomy?
Yeah, if your posterior superior rim is deficient, you might try and you fail through the left upper pulmonary vein, it slips recurrently, then probably you can use the right upper pulmonary vein.
So we are really running short of time, and there are a lot of questions which can come from this. I think we should go to the next presentation in the interest of the time.